So are the slides now moving?
They are, yes. Well done.
Great, so that's the first hurdle overcome. So our QI project has been looking at our transition clinic. We don't have a team picture, unfortunately, and we're not allowed to all actually stand close to each other at present to obtain one. So here's a picture of the leafy outside of our hospital instead. So it really is our whole transition team that has been part of this project, which is made up of consultants from both the paediatric and adult side, diabetes specialist nurses, again from both paediatrics and the adult team. We've got a dietitian from each side and a psychologist, Laura, who works primarily with the paediatric team. So the goals of our project really were to try and improve our transition clinic, and we decided that was a little bit too vague, so we tried to drill it down a bit further, aiming to improve the patient experience, both the time they spend with us in clinic and in between the appointments with the service we offer, to reduce the increase in HbA1c that we see in this patient group, and importantly to prepare our young people for their transition both to adult services and, more importantly, to adult life in general. This is a brief outline of the structure of our service. The 0 to 12-year-olds are looked after by the paediatric team, and they attend the paediatric clinic, which takes place in children's outpatients, which in a pre-COVID world is full of toys and bright lights and exciting things for them to do. We then take our young teenagers between 13 and 15 who continue to see the adult team, but they see us in the adult outpatients area. So it starts them to get used to these slightly different surroundings, but still the familiar team that they're used to. Then between 16 and 18, we have the transition clinic where they're looked after jointly between the paediatric and the adult young persons team, again seen in the adult outpatients. And then at 19, they transfer fully to the care of the adult team and are seen in their young person clinic. One of the significant factors with our transition clinic is that 40% of our patient caseload as the paediatric team is in this 16 to 19 service. So they do make up quite a large number of our young people, and they do tend to, just by the nature of being teenagers, they're generally less receptive to our input. They spend more time away from their parents than the younger children do, and there's a lot of other things going on: exams, issues with friends, boyfriends, girlfriends, moving away from home, off to university, getting jobs and employment, mental health issues, eating disorders. There's a huge amount of other things other than diabetes going on with this patient group. The data which really drove us to think of the need to improve our transition service really came from our audit data in 2018, which showed us, when we broke down the numbers slightly more with some help from our network, that our median HbA1c in the 10 to 14-year-olds was 60, and then this rose to 74 in our 15 to 19-year-olds. And when that year's audit data was peer reviewed with all our other units in the network, we showed that we actually had a better than average HbA1c for all the younger age groups, but then a worse than average HbA1c for these 15 to 19-year-olds. It may be skewed because we have lots of 17 to 18-year-olds, and if you're comparing them with someone else's 15-year-olds, that might explain some of the data. But regardless, we knew that we had this big jump in HbA1c in this age group that we wanted to do something about. And our audit data continues to show that we're a negative outlier for HbA1c. Our median HbA1c is high, and we have a large number of patients who have a high HbA1c. And we know that the majority of these patients are concentrated in this 16 to 19 clinic. So we mapped out the process of what happens within the transition service. How do the patients get into the service? How do they get into clinic? What happens when they're there? What happens after clinic? And then we drilled down even further with what happens on a particular day in clinic, and what happens at that early transition where they move from our young teenager service through in to our transition clinic? Do they really know what's going on? Do they really get introduced to the adult team the first time they see them? And most importantly, do the adult team get introduced to them, or do we just assume that they know them the same way that the paediatric team do? We then looked with our fishbone diagram about how the structured process through transition works and where we could make improvements. And at this point, we identified that a big problem was that only around 50% of the spaces in each clinic were being booked by patients that actually turned up. So we realized that we could make the clinic experience as fantastic as possible, but if we weren't actually getting people in the door, then we needed to fix that first. We also identified a lot of other areas where we wanted to make improvements. And I think at this point, we probably, like most people, we started to feel a little bit overwhelmed that there was a lot to do and we didn't seem to be getting anywhere with it. And then we completed our driver diagram as well, which helped us to drill down some of these problems which we'd identified in the fishbone diagram into more manageable tasks. So we first of all decided to try and make sure that patients are actually given the appropriate appointments, then to make sure that the team in clinic knew the patient. So members of the team have been doing some work to help with the pen portrait introduction, and we revigorated our pre-clinic MDT where we discussed the patients before they turn up. We made some changes to our clinic pro forma and our transition leaflet. We looked at some of the areas where care processes weren't working and what was happening after clinic when plans were agreed in clinic, but not all of the team weren't necessarily aware of this plan, and sometimes it involved the specialist nurses being expected to do something in between clinic appointments, which maybe wasn't always communicated clearly to them. So things that we've achieved, we feel we've tackled the appointments issues reasonably well. Booking and the queue management for this clinic is now much better. We do still have problems with last minute cancellations and DNAs, which are fairly inevitable in this group, but we are starting with a fully booked clinic. And the key worker for the patients now from the age of 18 is the specialist nurse from the adult team, which means they're definitely getting to know the patients before they transfer over to adult services. We've just sort of made ourselves get better at the things we were sort of doing before, but we've really made it part of the process of business as usual now and made sure it's happening every time. We have an MDT before clinic where we discuss the patient, the 16 to 19 caseload in general, but particularly the young people who are coming to clinic that day. Due to the timing of our clinic, it's a late afternoon, early evening clinic. We weren't able to have a post-clinic meeting to make sure everything was handed over and any issues were mopped up. So we've introduced an email huddle where every stream in the clinic emails the whole team with a list of the patients, what was discussed and what the plan was for the future. We've got a regular fortnightly QI meeting, which we've now introduced, which just helps keep us moving forward. And we've added a couple of extra out of clinic meetings. All the nurses now meet to discuss the patient caseload outside of our usual meetings. And when patients are starting at 18 to move over to from their paediatric key worker to their adult key worker, they've been having, pre-COVID, it was going to be a sort of coffee meeting where they could have a bit of a social chat and introduce each other. That's obviously had to take place virtually at the moment, but the plan is to introduce a sort of informal meeting where the paediatric key worker can hand things over to the adult nurse. We've still got several projects that we've started and not finished. We're looking at the Ready, Steady, Go transition paperwork to make sure we've got a curriculum and a formal structured process. We've got a several draft in transition leaflet, which explains the services to patients and their families. And we've also developed, in conjunction with other teams that we found doing similar projects, a stepping up form which the nurses or other key workers use with the young people to hand over the relevant details about them and their life and their history with diabetes when they join the clinic. We're going to continue to refine and improve this. We need to get patient feedback on how we're doing, and we're hoping to return to face-to-face clinics where possible for the majority of patients as soon as possible. We're currently somewhere between 50% and 2/3 face-to-face, and we really feel like video clinics were okay for keeping things ticking over when we were really in the midst of COVID crisis, but actually we're not giving patients as good a service as we are seeing them face to face, and we really need to get back to seeing as many patients face to face as we possibly can. Obviously allowing the option of video clinics if people are needing to self-isolate or other things, but really face to face should be the norm for our clinics in the future. And just a bit of data about our service. We started in 2010, 2011 with our audit data showing that we really had a good level of patients with a low HbA1c. We see a bit of a dip in 2013 when we start adding the 16 to 18-year-olds to our data, but again, we see this improve, and then we've had a dip down again. The rest of England and Wales was improving around us due to best practice tariff and all the other standards that have come in with that. And really, we were sort of starting to fall behind, but we've had an investment in staff from 2017 onwards, which we're starting to see some impact in our numbers. Similarly, with our patients with a high HbA1c, we started out with a similar level to the rest of the country. They've improved around us, and we've been a bit slow to catch up on this. We're hopefully starting to see some consistent improvement in that now. And this is our most recent HbA1c run chart. This is looking just at our 16 to 19-year-olds. So quite consistently throughout 2018, 2019, around 40%, often over 40% of our young people will have an HbA1c higher than 75. In our most recent data from the last quarter, that's gone down to 30%. So we are starting to see that improvement. Unfortunately, we don't really have any 2020 data for obvious reasons. So further things to consider in the future, we're going to relaunch DigiBeat for our older teenagers. We need to complete a business case for more dietitian time. We need to look at the patients with type 2 diabetes. We've mainly concentrated on those with type 1 so far, and we certainly have a rapidly growing cohort of teenagers with type 2, which previously we haven't really considered their needs, and we need to undertake a feedback exercise with our young people.